الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Fever, some practical points by Professor Mahmoud Hani Sulaiman. I mean by practical points, the points you may find at your clinic or hospital. Guiding questions of this lecture. Which region of brain is primarily responsible for temperature regulation? Does core temperature vary at different times of the day? Is fever beneficial? How and when should fever be treated? How do acetyl salicylic acid and acetaminophen act to reduce fever? This is the first part of the lecture. Regulation of temperature, body temperature regulated by anterior hypothalamus in combination with many other neural structures including brainstem, spinal cord, and sympathetic ganglia. Region of hypothalamus near optic chiasma is thought to be responsible for maintaining body's core temperature. A distinct temperature set point is established. When body core temperature drops below set point, CNS increases body metabolism and stimulates shivering and chills. When core temperature exceeds that set point, CNS increases peripheral blood flow and sweating occurs. So it is mechanized centrally at CNS. Temperature regulation, normal body temperature is 37 degrees centigrade and varies from individual to individual following a normal distribution. So some individuals have a lower set point and others have a higher set point than mean normal temperature. Furthermore, each individual's core temperature varies during day, being lower in morning and increase in evening. Lower in morning, increase in evening. Before diagnosis a patient to have a fever, physician must be familiar with that patient's normal set point and diurnal core temperature variation. Mechanisms underlying febrile response. Fever is a consequence of anterior hypothalamus responding to inflammatory mediators. Among mediators, increased normal core temperature set point are interleukin 1, tumor necrosis factor alpha, interleukin 6, interferon gamma. These cytokines released by monocytes and macrophage in response to invasion by pathogens and by other inflammatory stimuli. Cytokines stimulate circumventricular organs near optic chiasma, activating phospholipase A2, which in turn stimulates cyclooxygenase to produce increased levels of prostaglandin E2, which crosses blood-brain barrier and stimulates neurons in anterior hypothalamus and brainstem responsible for thermal regulation. Benefits and harmful effects of fever. Fever is a warning sign for onset of infection. So we know that we have something wrong. So go and hurry to treat it. Growth of some viruses, bacteria, fungi, and parasites inhibited by increase in temperature more than 37%. Growth of some viruses, some microorganisms inhibited by increase in temperature. Fever enhances ability of macrophage and neutrophil to kill pathogens and to improve cell-mediated immune function. Enhance ability of cells to kill pathogens and improve cell-mediated immune function. Fever may also have harmful effects. Patients with heart disease may suffer cardiac ischemia due to increase in heart rate and oxygen demands associated with fever. So patients with heart disease, we may treat fever. Patients with heart disease may suffer cardiac ischemia due to increase in heart rate and oxygen demands associated with fever. Also, patients with severe pulmonary disease may be unable to compensate for increase in oxygen demands associated with fever. So in these patients, treat fever. Elderly patients with limited mental capacity may develop confusion and lethargy in response to fever, complicating their care. So we may treat fever in these elder patients. Treatment of fever. Primary treatment for fever is to treat underlying cause. This is the most important. Role of lowering body temperature while trying to determine primary cause of fever remains controversial. It is not accepted by all clinicians. Based on current understanding of thermal regulation, direct cooling of body by using ice, cold water, and so on should be considered only in conjunction with medicines that reset thermal set point. Considered only in conjunction with medicines that reset thermal set point. Otherwise, CNS will respond to such measures by inducing shivering and chills and increase patient discomfort. Antibiotics is warranted in patients with heart disease, pulmonary disease, and elderly patients. Treatment of fever. Pharmacological agents used to reset thermal set point inhibit prostaglandin synthetase activity, decrease prostaglandin E2 production, acetyl salicylic acid, ASA, non-steroidal anti-inflammatory drugs, and acetaminophen are all effective. In children, ASA avoided due to high risk of Reye's syndrome. Acetaminophen avoided in liver disease. Coronary artery vasoconstriction associated with non-steroidal anti-inflammatory. So these drugs not used in patients with ischemic heart disease. To avoid repeated shifting of thermal set point and recurrent shivering and chills, antibiotic agents must be given on regular schedule until primary cause of fever treated. Management of new onset fever in hospitalized patient. He is in the hospital for any cause, and after 1 day, 2 days, 1 week, he got fever. What is the problem? One of the most common problems seen in infectious disease evaluation of new onset fever in a patient managed for another medical problem in the hospital. They often have multiple medical surgical conditions and may appear severely ill. In post-operative patient, wound infection. You must look for the wound infection. In immediate post-operative, Streptococcus pyogenes can lead to septic shock. Gram stain of serous oxidate usually demonstrates gram-positive cocci enzymes. In later post-operative period, staph, including MRSA, other pathogens as Pseudomonas, Klebsiella, and Escherichia coli are associated with the wound infection. Chronically ill patients, back and buttocks examined due to the decubitus position, back and buttocks for tissue breakdown and purulent discharge. The organism associated in this case is mostly Bacteroides fragilis. Therapy of hospitalized patient continued. Empiric antibiotic treatment should include gram-positive and gram-negative coverage. If patient has bowel perforation, development of intra-abdominal abscess is common cause of fever, and abdominal CT will reveal it. Most ICU patients are intubated, which may lead to bronchitis and pneumonia. Patients in less acute wards are also at increased risk of aspiration pneumonia due either to stroke or sedative. Sputum gram stain is important. Sputum culture is also very helpful. Chest X-ray, arterial blood gas may indicate pneumonia. Therapy of hospitalized patient. IV catheters may be found. Line sepsis is a common cause of fever in hospitalized patients. At onset of new fever, all IV and arterial lines should be examined for erythema, warmth, and exudate, especially if he developed shock. All lines removed and appropriate empiric antibiotic coverage instituted immediately within 1 hour. Staphylococcus aureus, Staphylococcus epidermis, and gram-negative rods are primary cause in these lines. Treatment should include vancomycin and third-generation cephalosporins. Also, fluconazole and other antibiotics are helpful. Still in therapy of hospitalized patients. Another major infectious cause of fever in hospitalized patient is prolonged bladder catheterization. Bladder catheter bypass urethra despite use of closed urinary collecting system. Nearly all patients with bladder catheters develop urinary tract infections in 30 days. So urine analysis and urine culture will be helpful, and sinus film will be helpful to diagnose sinusitis. Non-infectious causes of fever also need to be considered. Pulmonary emboli may be present with fever. Patients are usually receiving large number of medications and so at increased risk of developing drug fever. All medications reviewed, and when possible, medications should be discontinued or changed. Also, undrained collections of blood may be a cause. CT scan will be helpful in this case. Many antibiotics will lead to selection of highly resistant bacterial pathogens, which is very harmful to the patient. Key points about the definition of fever of unknown origin. Fever must persist for more than 3 weeks to exclude self-limiting viral illnesses. Temperature must be more than 38.3 to exclude normal variations in core body temperature set point. No diagnosis is reached after the 3 days of testing. Cause of fever of unknown origin: major or miscellaneous. Major: infection, neoplasm, autoimmune disease. Miscellaneous: drug fever, factitious fever, familial Mediterranean fever, pulmonary emboli, subacute thyroiditis. What is the factitious fever? الحمى المصطنعة. عيان بيصطنع ان عنده حمى، يجيب ترمومتر ويسخنه بأي حاجة ويعرضه عليك. Clues to the diagnosis of factitious fever: a patient who looks well, absence of temperature-related changes in pulse rate, temperature more than 41 degrees centigrade. Most probably he will increase the temperature of the thermometer to more than 41 degrees centigrade. Absence of sweating during the period of fever, normal ESR and PC and CRP, C-reactive protein, despite high fever. Useful methods for detection of factitious fever include supervised observed temperature measurement. يعني he must measure temperature before you, in front of you, measuring the temperature of freshly voided urine. The urine has the same temperature as the body. Infectious causes of fever of unknown origins: abscess, osteomyelitis, subacute bacterial endocarditis, biliary system infections, urinary tract infections, TB, spirochetal infection, brucellosis, rickettsial infection, chlamydia, Epstein-Barr virus, cytomegalovirus, fungal infection as histoplasmosis, parasites as malaria, toxoplasmosis, and trypanosomiasis. Drugs that cause fever of unknown origin: antihistamine, isoniazid, barbiturate, nitrofurantoin, chlorambucil, penicillins, phentoin, procainamide, hydralazine, quinidine sulfate, ibuprofen, salicylates, iodides, thiouracil, aldomate, mercaptopurine. History of fever of unknown origin helps narrowing differential diagnosis and choosing diagnostic test. Review of all symptoms associated with illness, periodically updated. This is important, periodically updated in this slide and in coming slides, because the case may change from time to time. So every day you must look for this. Symptoms often are transient and needs repeated questioning. He will not mention them unless you repeat the questions many times. History of TB, TB exposure or a positive PPD, family history as cyclic neutropenia, familial Mediterranean fever, social history, animal exposure, environment and occupational exposure, travel history, should explore travel to endemic areas of malaria, parasites, typhoid, coccidioidomycosis, histoplasmosis, and tick-borne illnesses, and exclude possibility of drug fever. About the history of in fever of unknown origin, review of symptoms, medical history of infectious diseases, family history, epidemiology history, all medications must be reviewed. Physical examination of fever of unknown origin. Repeat, careful repeat of physical examination. Skin examination, nail beds, joint motion, eye examination, all lymph nodes, cardiac examination, and abdomen palpated. Repeatedly, because this may change from day to day. Key points about physical examination: thoroughly examine skin, palpate or lymph node, perform complete joint examination, listen carefully for cardiac murmurs. Abdominal examination should assess liver and spleen and should palpate for masses and areas of tenderness. What are about infectious causes of fever of unknown origin? Again, infection is most common cause of fever of unknown origin in patients under 65 years. Epidemiology as animal exposure, insect bites, outdoor camping, travel, and exposure to infected humans is helpful. Physical examination may provide useful clues, particularly inspection of skin, nail beds, and fundi and cardiac auscultation. Abdominal abscesses, miliary TB, and disseminated fungal infections can be fatal. Prior antibiotic administration interferes with diagnosis. Preliminary tests recommended for fever of unknown origin: complete history, careful physical examination, complete blood count with differential diagnosis, HIV antibody and antigen test, liver function test, LDH and CPK, anti-nuclear antibodies and rheumatoid factor, CRP or ASR, urinalysis and urine culture, blood culture, serum protein electrophoresis, tuberculin test, chest and abdominal CT scan. هنا أستطيع أن أقول الحمد لله رب العالمين و thank you for your good listening.